We're live, Chairman.
Thank you very much, Elaine. Good morning, everyone, and welcome to the Public Health Community Safety Panel for Friday, 12th of September at 10 a.m. The Council will be holding this meeting electronically. Members of the public may also attend this meeting in an electronic capacity, and there is a link on the Council's website for them to do so. Members of the board are asked to keep their microphones switched off until called to speak and to switch their microphones off once they have finished speaking. Cameras may be left on throughout the meeting if members wish. If you experience a connection or other technical issues, it may help to switch your camera off. Cameras should be switched on if and when speaking in the meeting. To indicate a wish to speak, members should use the raise hand function. Use of the meeting chat function is exclusively for voting. At the end of the debate on each item of business, there will be a vote. You should vote using the meeting chat function by indicating for, against, or abstain. I will declare the result after each vote. So I'll announce some membership changes. So Stuart Roberts is substituting for Sean Prendergast. We have no apologies other than that. So I'll move on to members' interests. So if you consider that you have disclosable pecuniary interest in any matter to be considered at the meeting, they must declare that interest and must not participate in or vote on that matter unless a dispensation has been granted by the Standards Committee. And two, if you consider that you have a declarable interest as defined in paragraph 5.3 of the Code of Conduct for members in any matter to be considered at the meeting, they must declare the existence and nature of that interest. If a member has a declarable interest, they should consider whether they should participate in consideration and vote on the matter. Can I ask members to indicate if they do have disclosable pecuniary interest or declarable interest, please now? Thank you. So we'll move on to the order of business. So there are no chairman's announcements. So point number one, minutes. Please can I invite the panel to agree the minutes of the Public Health and Community Safety Cabinet Panel at the meeting on the 8th of July 2025. So please can you vote by show of hands, which I think, Elaine, means this? Or do you want us to raise our hand, Elaine, on the raise hand function?
Sorry, can we just agree in the chat like David's done? Thank you.
Great, thank you very much.
That's agreed, Chair. That's agreed, Chairman. Thank you.
Thank you. We have no petitions, and now I'm going to introduce the presenting officers prior to each item. So we'll move on to the main order of business, or the only order of business, and that's the award of the contract for the provision of public health nursing services. The presenter is Aideen Dunn. So I've got an important announcement to make because of the nature of this meeting. So please note the following report has a part 2 report and a part 2 recommendation. Only the part 1 element should be discussed first, and I can please remind members, obviously it's very sensitive, so please do not mention any contract names or part 2 business until the part 2 discussion. And members will also be aware from recent communication that we've had some very recent correspondence from an interested party. I just wanted to state that publicly, but we will be going into that detail in part 2. So please can members acknowledge that. Thank you. I will now invite Aideen to present the part 1 report and invite part 1 discussion. When this is concluded, I have a statement to make. So I'll now hand over to Aideen. So thank you very much.
Thank you. The purpose of this paper is to give an overview of the planned changes to the public health nursing contract, to give an overview of the procurement process that we launched in March of this year. On panel today are being asked to recommend to Cabinet to award the contract to the preferred provider identified in the part 2 paper. So I shall give a high level, because this is quite a complex service and a long process. I'll give a high level overview and then very happy to answer questions. So public health is an important service. It's a county-wide service. It's arguably one of the most important services we commission for children and young people in public health, and it comprises a health visiting and school nursing component. It covers from pregnancy right up to 19 and up to 25 years of age for young people with SEND, special educational needs and disabilities. The service is a prescribed function of the public health grant, so that means that we are expected to commission it. The current contract is in its extension period, and that's due to end on the 31st of March 2026 to align with the new contract to go live on the 1st of April. In 2024, we undertook a transformation program of public health nursing service. So the current contract has been in place since 2018, and we've had the current provider in place since at least 2000. We felt that we wanted to do a transformation program to modernise the service, to ensure that it was affordable, to ensure that it met the changing needs of our local population, and to ensure that we were more closely aligned with national policy and best practice. Just to give you a highlight, some of the key changes that we have made to the specification as a result of that transformation program includes that aligning with national policy, so that ensuring that those mandated health checks and health visiting are all delivered as face-to-face. The introduction of a school readiness check in the health visiting service, so offering that additional touch point with families to ensure that children and families are school ready. Resetting the role of public health nursing with regards to safeguarding, so pulling public health nurses out of some of the statutory responsibilities that don't sit with public health nursing. And we've also introduced an additional offer within school nursing, where all children who are identified as missing from education or electively home educated receive an annual health needs assessment. And that first health needs assessment is delivered within 3 months of that young person or child disengaging in the education or opting to be electively home educated. We've also given careful consideration as to how we deliver a county-wide service that also has a local focus and a population level focus. And we built that flexibility into the delivery model of the service. In terms of how we recommissioned the new contract, there was careful consideration as to what our options were, but we felt that an open competitive tender was in the best interests of residents and the council. So we launched an open competitive tender process back in March. We had a very comprehensive tender evaluation panel. This included membership from the University of Hearts, from Children's Services, from our Integrated Care Board, from Education, Send and Inclusion, and within the public health team. We ensured that we had a robust process in place because we're very aware that this is a high value contract. This is an important local service. There is significant public interest in the service and significant political interest in this service. I'll pause there and I'm very happy to answer any questions.
Great, thank you, Aideen. I know this is very helpful that we ran through this at the previous panel as well. So thank you again for reiterating how important the service is. Councillor Hale.
Yeah, thank you for the report and for your presentation. Were you satisfied with the number of bidders you received? And was that a reflection on the current market, i.e. were those the only bidders, the only organisations out there bidding for this sort of work? Or were there other organisations you might have expected to bid who didn't bid? And did you do any inquiries as to why they didn't bid?
Thank you. So in terms of potential bidders, there are many that we identified through our transformation programme. And for all organisations that we met with during our transformation programme, they were, through those engagements, aware that we were looking to re-tender this service. So I think that awareness, that market awareness. Prior to me starting in 2023, there had been a market engagement exercise undertaken, signalling that in the near future we will be re-tendering this service. In terms of, are we satisfied with the number? I suppose if you have 20 versus 2 or 3, all you need is that one really strong submission, and that you're satisfied with the quality. So on reflection, based on the tenders that we reviewed, we're happy with the submissions that we received.
Thank you for that. Councillor Kelly.
Thank you, Madam Chairman. Just a couple of points. One of them is obviously the importance and the raising. It's on item 2.3, and it's the when you reconsidered the actual tender, you redesigned the public health nursing system in regards to safeguarding. I wonder if you could just say a little bit more about that, because I know that's an important part of this provision. And the other one is in terms of the monitoring of nursing with mothers, you know, during pregnancy, you said, and then afterwards, do you feel that the provision afterwards is enough to enable a good monitoring of the mums and their children afterwards? Because I know I've heard some concern about some of the monitoring that's gone on nationally that hasn't been quite up to level. Okay.
Thank you, Councillor Kelly. So in terms of safeguarding, we undertook a review of our involvement in safeguarding as a system partner. So safeguarding is everyone's business, and public health and the public health nursing service are one of many partners. What we identified was that there were a number of statutory responsibilities that don't sit with public health nursing as a statutory duty. And there's very clear conditions on the public health grant that public health nursing should not be, that the public health grant should not be used for statutory functions, because those functions receive separate funding. So our first focus was ensuring that we weren't, I suppose, undertaking work that wasn't our responsibility to do, but that we continued to contribute as a key partner. But the impact of doing work, I suppose, that didn't statutorily sit with us is that it was taking away. There was an opportunity cost to a workforce that's already under pressure. And you'll know that nationally there's a shortage of public health nurses. So it was about recognising that that is a very important specialist resource and ensuring that we were prioritising that resource to deliver against the priorities of the service. So it was really about rebalancing the role of public health nursing in some of that reactive safeguarding, but strengthening our input on that upstream preventative work that prevents or can intervene early and prevent the escalation of safeguarding. So the example that I gave of that school, the check for children that are missing from education and electively home educated, there are nationally concerns regarding safeguarding, not for all of those children. So being electively home educated isn't a safeguarding risk. But it's the fact that within those children, there are less eyes on some children where perhaps you would want to have greater oversight. And that annual contact is an additional contact that doesn't exist now, that allows school nurses to build a rapport with those families. And they are very well placed and very well trained and experienced to identify any concerns very early. Within our specialists and our targeted pathway, which are for families that either have acute needs or require more additional support, they get more checks. And that is, again, additional safeguarding opportunities. But it's also, and this will lead nicely into your second question around that monitoring piece. By having home visits, and we were really keen to protect that focus on home visits, we have healthcare professionals going into the home, and that's not about checking up on families, but that's about being in the home environment, observing and understanding the dynamic and being able to give tailored advice in that setting. And that's really important. And actually those home visits are really important from a safe sleeping perspective, which is also one of our priorities. In terms of those contacts, and is that enough? Compared to national and compared to, I think, our regional colleagues, we have what's often reflected as a gold standard service. So we have maintained all of our contacts as face-to-face. Our antenatal contact was one that wasn't in the home, and we are going back to home-based antenatal contacts for our targeted and our specialist families. We have a tiered service, and that's based on need. So we proportion resource based on level of need. So universal families, you might say, in general, we have no concerns. That's not to say there, something couldn't occur or they might need time sensitive support or additional support. But in general, Universal will have a lower level of intensity of contact from public health nursing, but they will still get their 5 mandated checks and the school readiness check. For other families, and I don't have the pathways in front of me, but in the service specification for targeted families, so they're families where we often talk about risk factors like substance misuse, and perhaps a young parent, they may get up to 7 additional contacts. So they will get an additional contact at 3 months and 6 months, and they may get an additional contact at 18 months. But also there's that professional curiosity, and that may be tailored up or down as required. Children on the specialist pathway are children known to safeguarding, so children's services, and they will get on average a visit every month in the first year of life, and then the extra visits thereafter. In terms of are they doing well, the other thing that we've implemented in the current contract that we're now mainstreaming is that a mental health and wellbeing screening for both parents. And we introduced that in our mandated checks, and that's been recognised nationally as an example of good practice. So we do prioritise both dad and mum or both partners. And going back to the safeguarding point, invisible dads has been highlighted as a key safeguarding area of concern. So we believe by including them in that screening, that's part of engaging the parent, the partner in the care of the infant and supporting the mum.
Is that okay, Councillor Kelly? No follow-up. Great. Councillor Herring, please.
Thanking you. First of all, I need to just ask a question to make sure that I'm on the right track, because this might be relevant. Does the service provide for the assessment of an EHCP?
So they're not the lead organisation on an EHCP, but they may be one of the key partners that would feed into that. And they very much want to be involved in that. So school nursing will support children in mainstream schools. And so they won't be the lead agency, but they very much feed into that.
Okay, I just have one point of feedback to make. Any provider needs to be assessed on their approach on doing an assessment. From a personal experience, I know that ended up having to take the council to court in order to get an EHCP, and in that judicial review, Hertfordshire become heavily criticised for failing to take on the responsibilities of doing the assessment. The issue seemed to be that it seemed to be a blanket assessment rather than an individual assessment based on the merits of each individual case. So everything was looked at across the board, and because of that, the person who it was applied to was refused when the judge actually said that it's beyond belief that this has actually come to this stage. This should have instantly been granted immediately. So that my only point of view there is that any provider needs to have a clear insight as to what it is they're dealing with, and not just approach it all with one view, because it doesn't fit.
Thank you. Apologies, my connection cut out. I did hear the majority of what you said, but we'll very much take that on board as we mobilise the new contract as well.
Thank you.
Thank you, Aideen. Councillor Wren, please.
Thank you, Chair. I just a quick question, please, about 4.2, the population modelling. Given that there is at the moment a reduction in the number of school children, or the youngsters or children actually entering primary school, but we are expecting, I think it's called a sort of COVID bump. Are you satisfied that the tenderers sort of really did look at the present number of nurses that they will be providing and their ability to scale up should the number of children be increasing in the future, which is, I think, expected? Thank you.
Thank you. So we population modelling is always an estimate, and you're using the best available information that's available at the time. So we would have used existing birth rates, so that COVID bump that you talk about would have been captured. This service covers 0 to 25. So in modelling the needs for health visiting, you are also modelling the future needs of school nursing as that cohort aged through the service. So we did very comprehensive population modelling with our evidence and intelligence team, covering the span of the contract up to 2030. So I feel that our estimates are based on the best available knowledge at the time of doing the modelling. In terms of workforce, what we have done to recognise workforce challenges, and that is a national issue, and retention, is that we have looked at also the value of a skill mix. So you have your, they're called SCIFNs, so specialist public health community and school nurses. We have indicated within the specification, I suppose, a degree of flexibility in terms of how the provider allocates a workforce to deliver against the specification. But we've clearly signalled that the specialist and targeted pathways, so those families that require that additional support, that higher graded SCIFNs are prioritised to support those families. And similarly within school nursing. So recognising you've a limited workforce and the opportunity cost of anything they do, they're not doing something else. We ensure that that workforce is prioritised for the higher need families and young people. But where we have a skill mix, so they could be lower graded public health nurses or a different background other than nursing, that there is caseload oversight by a public health nurse. So it's a way of managing and balancing, but ensuring that the service remains safe and that the service user gets the same quality experience.
Thank you, Aideen. Thank you.
Thank you. Councillor Crystal, please.
Thanks, Chair, and thanks, Aideen, for the report. That's really helpful. It's really good to see that the offer includes health needs assessments for those who are home educated, and I wondered whether it's possible just to sort of understand how the offering in this one compares with those offered by other authorities in a similar position to us. Is there any sort of comparisons possible?
Yeah. I don't have to say we're the first in the country because it's a public meeting and I wouldn't be that bold. We didn't identify any other area through our transformation programme that was doing this. And we engaged with 16 local authorities and across Wales, England and Scotland. The need for this, from my perspective, was identified through a collaborative piece that Public Health were doing with our colleagues in Children's Services and with education. And also working with the independent scrutineer for the Hertfordshire Safeguarding Children's Partnership. So this element of the service, I feel, was really born out of that partnership working and identifying that we have this growing, at the time it was a growing cohort, I think we have managed to stabilise it, of young people disengaged in or not in the school setting. And from a public health nursing perspective, they're not there to receive, you know, the vision and hearing screening that you get in reception, vaccinations delivered through school. So, you know, whilst I was absolutely supporting that wider priority of how do we get them back into school, when they're not in school, how do we ensure they're not missing out on the health and wellbeing offer that we deliver? In the old specification, we did reference them, but it was quite a loose offer, as in you should make attempts to deliver something in the community, and it was quite loose. But because of the growing numbers and the size of that cohort now, we needed to have something firmer with a KPI that we could hold the provider to account to make sure that those children were getting something. The 3-month target of engaging them within 3 months of not attending school, and so that is where they have become missing from education or elect to be home educated. That came from the report of the independent scrutineer, where they identified that window of opportunity to re-engage. So we're feeding into that wider strategy of re-engaging young people in education and also ensuring we have that continuity of contact with them and that opportunity to identify health needs that we weren't aware of.
Fantastic. Thank you very much. That's really good to know.
Thank you.
Thank you, Aideen. That's yeah, very comprehensive answers for everyone. So I hope everyone is satisfied with those. I don't appear to see any more hands up, so we'll move on to the next section and some technical things I need to read out. So under section 100A, part 4 of the Local Government Act 1972, the press and public be excluded from the meeting for the following items of business on the grounds that it involves the likely disclosure of exempt information in paragraph 3. Information relating to the financial or business affairs of any particular person, including the council, of part 1 of schedule 12A to the said act, and the public interest in maintaining the exemption outweighs the public interest in disclosing the information. So I think we need to pause the broadcast, and Elaine's going to confirm when the members can come back in.
Yeah, I'll just confirm. We're live again, Chairman. Thank you.
Thank you very much. Right, so welcome back, the public who are listening. So now the members are asked again to vote again via the chat. So please can we be asked to recommend to Cabinet that we award the public health nursing contract to the selected provider as outlined in the Part 2 recommendation, please.
And that's unanimous, Chairman. Thank you.
Thank you very much, panel. Really appreciate that this is a special meeting that was obviously very important and had to go ahead. So appreciate you taking your time for this. So now there's no other Part 1 business that warrants consideration prior to the next meeting of panel. So there's no other Part 2 business either. So I can now conclude the meeting. The date of the next meeting is the 9th of October 2025 at 10 a.m. and this meeting in probably record time has finished at 10:54. So thank you very much, everyone.